Hi and welcome to Lecture 5 of the Understanding the ECG lecture series. My name's Phil Cam and I'm a cardiology registrar, and in this lecture we're going to go over narrow complex tachycardias. So our learning objectives for this lecture are as follows. 1, we want to be able to describe what makes up a narrow complex tachycardia. We want to be able to recognize the ECG patterns of different forms of narrow complex tachycardia. You can see some of those that we're going to cover on the right-hand side of the screen. Understand the physiology behind some of these forms of narrow complex tachycardia, and then describe the basic management of some of these patients. And then specifically to be able to understand some of the general management considerations of a patient with atrial fibrillation. So as usual, a quick recap on how to systematically go through the ECG. First start with the details, then go on to the technical calibration, the ventricular rate, the rhythm, noting whether it's regular and whether P waves come before each QRS complex, and that's going to be particularly important here as we're talking about tachyarrhythmias. The axis of depolarization for the ventricle, what the P wave looks like, and whether it's positive in lead 2, suggesting sinus rhythm. Whether the PR interval is an appropriate length, what the QRS complex looks like, and particularly in this case we're going to be talking about whether it's broad or narrow, whether there's any change in the ST segment, and whether there's any inversion in the T waves. So what is narrow complex when it comes to tachyarrhythmias? Well, firstly, and most generally, I think we're saying that the QRS duration must be less than 120 milliseconds to be considered narrow complex. And as we've talked about on previous lectures, what that means is that the ventricular depolarization is using the standard pathway that we particularly went into detail in lecture 4. Normally, the arrhythmia has to be of atrial origin, so that narrow QRS means that we're using that normal conducting system. The entry into that normal conducting system of the AV node His-Purkinje system is the AV node itself, and that's accessed via atrial depolarization. So normally these rhythms are atrial rhythms. The AV node, as that entry point into the ventricular depolarization, plays a really important role for both diagnosis and treatment of these arrhythmias. And of course, because we're talking about a tachycardia, we should say that tachycardia is when there's a ventricular rate of greater than 100 beats per minute. Okay, so these are the things to think about when we're talking about narrow complex tachycardias. So just to emphasize this again, in a narrow complex tachycardia, the depolarization of the ventricles goes via our AV node, His bundle, and then our bundle branches. And that it has to be using this system really to be a narrow QRS complex. Okay, and I think that's a really important take-home message from this lecture. So a bit of terminology now. I appreciate that discussing terminology can appear to be very pedantic, and I do appreciate that, but I think it's important that you have an understanding of some of the terminology so that you can accurately describe what you're seeing on an ECG and accurately discuss arrhythmias with other clinicians. So AV-NRT is a term that stands for AV nodal reentrant tachycardia, and that's different from AV-RT, which is atrioventricular reentrant tachycardia. They are often grouped together under the umbrella term SVT, which is in reality is a catch-all term for all narrow complex tachycardias. So as we described, narrow complex tachycardias use that normal conducting system. They tend to have an atrial origin, so they are all supraventricular in their origin, so supraventricular tachycardias. But most people, when they say SVT, really mean that it's either AV-NRT or AV-RT. So in terms of narrow complex tachycardias, you can really group the common forms into 3 categories. So you've got AV-NRT and AV-RT, and they can kind of be grouped together under an AV node group, and that's because both of them require the AV node to function. for the arrhythmia to generate. They both involve circuits, and if you can block the AV node, you can terminate those arrhythmias, and I will discuss that in quite a lot of detail. You've then got some atrial focal arrhythmias that I'm not going to talk about in huge detail in this lecture. They're things like sinus tachycardia, which normally essentially represents that the heart is appropriately beating quickly to meet the metabolic demands of the body. And so people with sinus tachycardia don't tend to have an intrinsic issue with their heart, and really you should be looking elsewhere to try and treat what is causing the heart to beat quickly. You've then got sinus nodal reentrant tachycardia, SNRT, and atrial tachycardia. Both of these are very uncommon, or much less common than the other forms of supraventricular tachycardia or narrow complex tachycardia, so I won't discuss them in a huge amount of detail. And then you've got this group of other atrial tachycardias, and in particular I will discuss atrial fibrillation and atrial flutter. I'm not going to spend any time talking about multifocal atrial tachycardia, but if you're interested in it, there's plenty online for you to look at. So yeah, these are the four that I think we're going to discuss in the lecture today. And as I said, SVT, although it is this catch-all term for narrow complex tachycardias, it's usually used to mean AVNRT or AVRT. So, AV nodal reentrant tachycardia. So it is an intrinsic issue with the AV node. So this is our normal AV node. I like to keep things as simple as possible. So here we have one, and this separates the atria from the ventricles. And what normally happens is the atria depolarize, and so I'm going to use the dark blue color here for depolarization through the rest of this lecture. So the atria depolarize, then the AV node depolarizes, and then the ventricles depolarize. And this is what happens in a normal AV node working normally. Now, some of us, and by some I mean probably around 30%, have something called dual node physiology. And instead of our AV node being represented as a nice circle, it's better to think of it like a donut. Now, this is a huge simplification because obviously the AV node is a three-dimensional structure, but I think for our sake, we can just think of it like this two-dimensional donut. So this is our AV node. And because it's a donut, there are kind of two pathways. You can come down this left-hand side of the screen or the right-hand side of the screen. And interestingly, in people who have dual nodal physiology, the pathways are not the same, they're not equal. And so you have one pathway that's called the fast pathway and one that's called the slow pathway. And essentially the fast pathway and slow pathway are separated in the middle. Okay, so let's have a look at how this works in practice. You can see that I've used F for fast and S for slow. I'll keep those pathways on the same side throughout this lecture to try and keep things simple. So as usual, our AV node separates our atria from our ventricles. The atria depolarize, and the signal is conducted quickly down the fast pathway, which is exactly what you'd imagine. It's called the fast pathway because it's able to depolarize quickly. At the same time, the signal is conducted less quickly down the slow pathway. And what this means is that the signal reaches the ventricles via the fast pathway first. And so the ventricles are depolarized via this fast pathway. And the signal then continues back up from the fast pathway. It continues retrograde up the AV node via the slow pathway because the pathways are connected at both the top and the bottom, like a donut. And so these two signals will meet each other in the middle and they extinguish one another. Okay, and so this is what happens each beat. So the signal goes down, both the fast and slow pathway, the ventricles are depolarized by the fast pathway, and then the signals are extinguishing one another as the signal goes back up the slow pathway and meets that downward signal in the middle somewhere. So after a normal beat, both pathways in the AV node are refractory, okay, and so they're unable to take another depolarization. But rather oddly, the slow pathway recovers more quickly than the fast pathway. So it's a slow pathway and it has a short refractory period. Okay, so the S is slow and short here. Okay, which means that it is ready for another signal, while the fast pathway isn't. So this isn't normally a problem when the heart is beating normally, because there's a long enough pause between P waves, between atrial depolarizations for both pathways to recover. But if you get an ectopic beat occurring in the atria, and it has to occur at exactly the right moment, then what will happen is that depolarization will reach the AV node when the slow pathway is ready to take a signal, but the fast pathway isn't. And so what happens then is the fast pathway is still refractory, so the signal travels down the slow pathway. And so the ventricles are then depolarized by the slow pathway. Now, by the time the signal has come all the way down that slow pathway, remember it's quite slow, so it takes some time, that fast pathway is now ready to receive a signal again. And these pathways, like a donut, are connected at the top and the bottom. And so the slow pathway is refractory. So during this time, the atria become repolarized again, and the signal, having got to the ventricles via the slow pathway, has caused that slow pathway to become refractory, but the signal is now able to travel back up that fast pathway, which is recovered in the time that signal has traveled down the slow pathway. Okay, so now it's gone down the slow pathway and it's coming back up the fast pathway. And that allows the atria to become depolarized again. And while it's traveling up the fast pathway, although that's a short period of time to go up the fast pathway, remember that slow pathway has a very short refractory period, so it's able to recover again. And so by the time the signal gets back up to the top of the AV node again, the slow pathway is ready to receive another signal, and that signal travels down the slow pathway again. And the fast pathway is refractory. The ventricles are depolarized via the slow pathway. By the time it's traveled all the way down this slow pathway, the fast pathway is repolarized again, and so the signal travels back up the fast pathway. And you can see here that this circuit essentially develops within the AV node, and it's just going quite quickly round, and it goes down the slow pathway and up the fast pathway. And it fires off and depolarizes the ventricles and atria as it reaches the bottom and top of the AV node, respectively. And that this cycle just repeats until something breaks it. Okay, so it's constantly trying to chase its tail. And so that's how AV NRT works. And so it's an intrinsic issue within the AV node itself. Okay, and it involves the presence of dual nodal physiology, in which that AV node is divided into those two pathways, and that's present in about 30% of people. And it requires this ectopic trigger. This extra beat is required to depolarize the AV node when only the slow pathway is non-refractory. So the slow pathway is ready to receive a signal while the fast pathway isn't. And that's what helps generate that circuit that we showed previously. Okay, so moving on from AV-NRT to talk about AVRT, atrioventricular reentrant tachycardia. I'm just going to quickly recap a normal heartbeat for you. So exactly as we've shown before, signal starts in the sinoatrial node, the atria are depolarized, causing our P wave. Signal goes through the AV node in what is our PR segment. The ventricle is depolarized using our standard conducting system, causing a narrow QRS complex. There's a ventricular plateau phase, which is our ST segment, and then the ventricles repolarize in our T wave. So I think the key thing you have to understand about AVRT is that it requires the presence of something called an accessory pathway. So normally the atria and the ventricles are electrically isolated from one another. The AV node is the only way for signals to get from the atria to the ventricles. But in some people, there's something called an accessory pathway. And this is just some additional conducting tissue which links the atria and the ventricles together. That's separate from the AV node. And so if you've got an accessory pathway, a normal heartbeat with an accessory pathway looks something like this. The signal starts in the sinoatrial node as usual, and atrial depolarization occurs exactly as it would normally. And the signal reaches the AV node, but at the same time, that signal passes down the accessory pathway. And this occurs while the main signal is still in the AV node. And so the signal is still held in the AV node, but the ventricles start to slowly depolarize. So the accessory pathway ends in ventricular muscle rather than in ventricular conducting tissue. So the ventricle starts to depolarize, but it's quite slowly because it's moving through ventricular muscle tissue. So similar to how we talked about the signal being much slower in bundle branch block as it tries to get through the muscular tissue rather than the conducting system. And so what happens is that you get this slurred upstroke of the QRS complex, okay? So you get this start of depolarization occurring. And this happens while the signal would normally be in the AV node. And so the PR interval shortens, okay? Because that signal is still being held in the AV node, but you're getting some depolarization of the ventricle with this slurred upstroke occurring as it depolarizes slowly through the muscle tissue. Then the signal leaves the AV node as it would in a normal heart and depolarizes the rest of the ventricle through the rapid conducting system, and so it kind of catches up. And so you get this short PR interval with this slurred upstroke, and then the rest of the QRS complex is narrow and looks pretty normal. But overall, that QRS complex may be broad because of this slurred upstroke, which is also called a delta wave. So that's what people are talking about when they say delta wave on an ECG. They mean this slurred upstroke at the beginning of the QRS complex. And then you get an ST segment and ventricular repolarization. Okay, so this is a normal beat with an accessory pathway. So how does having an accessory pathway lead to the development of an atrioventricular reentrant tachycardia? Well, similar to AV NRT, it normally requires an ectopic beat to occur. And essentially, that ectopic beat depolarizes the atria, but the signal reaches the accessory pathway while it's still refractory. And so no signal goes down that accessory pathway, but it is able to go down the AV node, and the ventricles depolarize via that normal conducting system. And so you get this narrow QRS complex. Interestingly, in that situation, because there's no signal going down the accessory pathway, there's no slurred upstroke. Okay, so you get a normal, narrow QRS complex. But then, by the time it reaches the accessory pathway, coming up from the ventricles, that accessory pathway is ready to take a signal, and so that signal comes back up the accessory pathway into the atria again, and is able to activate the AV node again. And so then the ventricles depolarize again via the normal pathway. So you get another narrow QRS complex, no slurred upstroke. And you can see that that signal, by the time it comes back round again through the ventricles, is able to reach the accessory pathway when it's ready to take another signal, and that signal goes back up the accessory pathway and will come around to the AV node again. And you can see that this cycle can repeat over and over again until something breaks it. So both AV NRT and AV RT are forms of circuit arrhythmia. Okay, so they form this big circuit that needs to be broken. Okay. So what do you need for AV-RT then? Well, we've already talked about most of this. So you need an accessory pathway, this extra electrical connection between the atria and the ventricles. And you need the AV node to be functioning. So wherever that accessory pathway is, the signal for this circuit arrhythmia still has to come through the AV node. And so if you can block the AV node, you can stop this circuit, which is exactly the same as AV-NRT. And you need an ectopic trigger. You need this extra beat to occur to depolarize the AV node while that accessory pathway is refractory and can't take a signal, which means that by the time the signal has gone into the ventricles, it's able to come back up the accessory pathway to re-stimulate the AV node. Now, what I've shown you is a completely open accessory pathway that you can see conducting both downwards and is able to then conduct back upwards. Not all accessory pathways are able to conduct both ways. And so in some individuals, you won't see this slurred upstroke on a normal heartbeat. The normal heartbeat will look completely normal because the accessory pathway can only conduct from the ventricles to the atria. And vice versa, you can have people who have this slurred upstroke, this delta wave, and the narrow PR interval because the accessory pathway is able to conduct from the atria to the ventricles. But you may not easily get this AVRT developing because the accessory pathway may not be able to conduct from the ventricles to the atria, and certainly may not be able to conduct fast enough for this arrhythmia to generate. So it requires a very specific type of accessory pathway. So here's another ECG example. I'll give you a few seconds to go through it, pause the lecture, and then I'll go through it afterwards. Okay, so hopefully you've had a chance to go through this. So let's start at the beginning. So details. So I haven't provided you any details as usual here, but I'll give you some now. It's a relatively young person and they're complaining of palpitations. Technical aspects of the ECG appear to be fine. So the calibration on that right-hand side you can see is as we would expect. Heart rate. Well, I think we can all agree that the rate is pretty fast here. So how fast are we talking about? Well, if we count up the QRS complexes, we see there are about 34 on this trace. The trace takes 10 seconds. So we multiply that by 6, and we see we're going at about 204 beats a minute. So really quite quickly. What about the rhythm? Well, I think the rhythm appears to be pretty regular, doesn't it? So I've plopped out some rectangles here. They're all the same width, and you can see the gap between the QRS complexes is the same each time. So we've got a regular tachycardia here. Now, I think that's perfectly reasonable, and I don't think we can say very much more than that at the moment. Okay, so let's have a look at the cardiac axis now. So if we enlarge these leads here, and we take our normal graph, looking at lead 1, we can see that that's predominantly upgoing. So upgoing means that it's coming towards the lead, and so we can get rid of everything that's on that left-hand side of the graph because it must be coming towards lead 1. Now lead 2 is a little bit more difficult in that, to my mind at least, I think that those QRS complexes are pretty balanced. So yes, there's a little bit of up, but there's an equal amount of down probably. And so I don't think that we can really say it's either going towards or away from lead 2, which means it's probably going perpendicular to it. All right, so I've given a bit of a margin of error here, which I think is not unreasonable. But I think we're sort of balanced in that lead, so it's going at 90 degrees to lead 2. So when we add those two together, the only area it can be is up in this little quadrant here, which is borderline left axis deviation, I think. Okay, so thinking about P waves now, the heart rate's quite fast here, isn't it? So it's difficult to see P waves. So I've blown up lead 2 here, which is normally the best lead to see P waves in. And honestly, I don't think I can see very clear P waves followed by QRS complexes. I don't think this looks like sinus tachycardia. And another clue that this probably isn't sinus tachycardia is the heart rate. So very crudely, our maximum heart rate is probably in the region of 220 beats a minute minus your age in years. And so this heart rate was about 204 beats a minute. So if this patient is over the age of, say, 20 years old, I think it's very unlikely that this is going to be sinus tachycardia because it's going faster than the maximum heart rate really should be. Okay, so the eagle-eyed of you, so no clear P waves, but the eagle-eyed of you might have seen these little bumps here occurring at the end of most of the T waves. So that T wave doesn't look like a nice, clean, single wave, does it? There looks to be an extra bump at the end there. And you might be saying to yourself, well, those could be P waves, couldn't they? And I think you're right, they could be P waves. And then you say, well, couldn't it then be sinus tachycardia? And I don't think it can be. Okay, so these I think could be retrograde P waves. And what do I mean by retrograde P waves? Well, I mean that this is atrial depolarization that is occurring back upwards from a signal from the ventricles. So it's either coming back up an accessory pathway, or it might be coming back up the AV node via that fast pathway in AV-nRT. And I don't think this is sinus tachycardia. One, the maximum heart rate is too fast, and the other is the PR interval here. Okay, and the PR interval appears to be around 60 milliseconds. Okay, so it's really short, and it's too short for it to be sinus tachycardia, where the P wave and the PR interval should probably be in the region of 120 to 200 milliseconds, so really way shorter than that. So what about the QRS complex? Well, I've sort of highlighted one here, and you can see that the QRS complex is short. It's about 2 small squares across, which makes it about 80 milliseconds. Okay, so given what we know so far, I think we can say that we've now got a narrow, complex tachyarrhythmia. And importantly, it's regular. Okay, and that's important because things like AV-NRT and AV-RT have those defined circuits, don't they? So that in AV-NRT, it's either in the AV node with the slow and fast pathway, or in AV-RT, it's the AV node and accessory pathway making a big circuit through the atria and the ventricles itself. But either way, those circuits are well defined, which means that the tachyarrhythmia is regular. Okay, and that's a key point to know, is that this is regular, which means that it could be AV-RT and AV-NRT, and whereas atrial fibrillation is irregular, and we'll talk about that a bit more later. So don't forget to go through the rest of the ECG. It's very tempting once you've found a finding, like we have here, to say, fantastic, I'm done. But actually, look at these ST segments. Okay, they're not normal. There's quite significant ST depression in these lateral leads. You can see compared with the interval, the point just before the QRS complex here, normally we would say the PR interval, or the PR segment you would use as your isoelectric, but there probably isn't a clear PR segment here, given what we've just been talking about. But we can take that point just before the QRS complex starts, and then look at that ST segment. It's quite depressed. Quite downward compared with that baseline. Okay, so there's some ST segment depression here. And this probably relates to the fact that the heart's going very quickly, which means the metabolic demands of the cardiac tissue are very high, and they're probably outstripping the amount of blood that is, and therefore the amount of oxygen that's being supplied to the heart via the coronary arteries. So this person, I don't think, is having a heart attack. They've just got some relative ischemia due to their heart rate. T waves look fine. Okay, so the T waves are all upgoing, with the exception of AVR and V1 where they're downgoing, and we've talked about that previously. And so in summary, we've got a regular, narrow, complex tachyarrhythmia with some signs of relative ischemia. Okay, so how do we go about disentangling AVRT from AVNRT? We've said that they both can present as this regular, narrow, complex tachyarrhythmia. Well, I think acutely it doesn't really matter because the treatment is essentially the same, and that's the treatment for getting them out of this tachyarrhythmia, and that's because both of them require the AV node to be functioning, as I've mentioned before. Okay, so you use things that target the AV node. Now for AVRT, you could look at features of the accessory pathway when in sinus rhythm. So you could look for that slightly broader QRS complex, for that delta upstroke, which won't be present in AVNRT, but might be present in AVRT. Now the caveat to that, as I've said, is not all accessory pathways conduct from the atria to the ventricles. You can have what are called concealed accessory pathways, and in that case you won't see these signs in sinus rhythm. But that's one of the things to do. Now, you can look at the morphology of the P waves, and you can look at what would be the PR interval and the RP intervals, and you may hear that being talked about, but that is far beyond the scope of what is required for medical school or for finals. So I'm not going to talk about that any further. And essentially, I think what for the extent that you need to know for finals, and for in fact, general practice doing most junior doctor jobs, is that essentially it doesn't matter hugely. And while they're in that fast rhythm, you just need to treat them, and you can treat them the same either way, whether it's AVRT or AVNRT. Okay, so here's another ECG example for you to go through. Take a moment to pause the lecture, and then I'll go through it with you afterwards. Okay, so hopefully you've had a chance to interpret the ECG. Let's start at the top as usual. So I don't have any details for you, so we can move on to the technical aspects, which show that this appears to be calibrated normally based on that rectangle on the right-hand side. Okay, the heart rate is probably ever so slightly slow. It's probably just over 5 large squares between each R wave, so it's just slightly under 60 beats a minute. The rhythm appears to be pretty normal, so there's equal distances between each of the R waves, and you can see P waves preceding each QRS complex, and those P waves are upright in lead 2. Okay, so this is almost certainly sinus rhythm. Cardiac axis also appears to be pretty normal, doesn't it? Looking at the P waves, again, their morphology looks pretty standard. They're not particularly large, and as I've said previously, they're upright in lead 2. Okay, what about the PR interval? Well, I've got to say I think it's a little bit short. So if we pull up a lead here, this is lead 2, we can see that that's the beginning of the P wave to the beginning of the QRS complex, and that's probably in the region of about 100 milliseconds. Okay, so that's shorter than we would expect, isn't it? Okay, what about our QRS complex? Well, actually, our QRS complex is a little bit broad, isn't it? Probably about 120 milliseconds, which is unusual, right? So normally the QRS complex, I know we say that normal is less than 120 milliseconds, but most people's QRS complexes are less than 100 milliseconds. Okay, so this is very much at the upper limit of what would be considered in any way normal. Okay, so let's have a look at these QRS complexes in a little bit more detail. So I've taken out lead 1 and lead AVL here, just to give you an enhanced look at them, because they don't look really completely normal. So here's how the QRS complex starts in lead 1, and that's how it finishes on that R wave going up. Okay, so you can see that it starts at one angle and then goes up, and the steeper the angle, the faster the depolarization. So there appears to be a period of slower depolarization in the ventricle, followed by a period of faster depolarization in the ventricle. Now, that is much more pronounced in AVL. You can see that that's the original angle, and then that's the final angle. So you can see that there's a period of very slow depolarization, followed by a period of fast depolarization. So this here, this bit of slow depolarization, that is your slurred upstroke. That's your delta wave, okay? And so this is essentially an ECG showing an accessory pathway. Okay, ST segments appear to be normal, and the T waves are not particularly abnormal. You may pick out that there appears to be flat, maybe slightly inverted T wave in lead 3, but I don't think that is pathological. So in summary, this is sinus rhythm with what's called pre-excitation. Okay, that's signs of an accessory pathway pre-exciting the ventricle before the AV node is able to depolarize it normally. Okay. So what are the principles of SVT management? Well, as with any unwell patient, is to take an ABCDE approach. Okay, all acute management should start with this, and I think it's really important that that is in your mind. Okay, because actually the arrhythmia is only C, so you need to make sure their airway and their breathing are okay before we get on to management of the arrhythmia. Okay, I would suggest, certainly while you're a medical student, but even while you're an F1 and probably into your early years of being an SHO, that if you're in any doubt, you should get help early. And the people you should be looking to get help from are probably the medical registrar, or if they're unavailable, the cardiology registrar. And I think that this is true of any situation where you feel like you are worried about a patient, you're not sure what to do, they look more unwell than you are able to handle. If in doubt, get help early. Okay, and in this case, it's medical registrar or cardiology registrar that you should be seeking help from. And then you should just follow the guidelines that are available. Okay, so the Resus Council in the UK has very clear guidelines, which I will be going through, and it doesn't require any cowboy actions, it doesn't require any heroics, it's just about using the guidelines as they're laid out, and they're very clear and very sensible. Okay, so I've adapted the 2015 Resus Council UK guidelines here. It's the same information, I've just put it onto the slide. So essentially, got to take that ABCDE approach. Okay, and that includes in this situation making sure you've got your observations, you've got IV access, you've sent bloods and a blood gas, and then you've popped them on ECG monitoring, and ideally got a 12-lead ECG. And the reason for getting a 12-lead ECG is that while this patient is acutely unwell, it's not the time to be fawning over the ECG and looking to see whether you can see retrograde P waves and trying to make some super smart diagnosis. Now is the time to try and stabilize the patient. But having that 12-lead ECG later may well be helpful for ensuring that they get the right diagnosis for the patient. Then you've got to ask yourself, are there adverse features present? And really we're talking about 4 things. So do they have features of myocardial ischemia? And by that I mean, do they have chest pain? Okay, so some patients will have some of that ST depression, like we showed on our previous ECG with their tachyarrhythmia. But if they've not got chest pain and they don't look particularly unwell, then I wouldn't worry just about that ECG finding. But if they've got chest pain, I would be concerned. And the same goes if they're in shock. And by shock, I mean they don't have very good blood pressure, so their blood pressure is less than, say, 100 systolic, I'd start to become quite concerned. And if you've got a catheter or any other way of measuring urine output, if they stop making urine, that's concerning. Equally, when you get your blood gas back, if it shows signs of shock, if they've got a high lactate, that would also be concerning. If they become syncopal, that suggests they're not getting enough blood to their brain. Very concerning feature. And if they've got features of heart failure, particularly, are they becoming breathless? Are they getting decreased oxygen saturations? These 4 are the key adverse features you need to look for. Because if they have one of these adverse features, you need to get senior help or advice immediately. And that's because you're probably going to need to undertake an urgent DC cardioversion. Okay, and that's not something that I think that you as a junior should be doing by yourself, and it's certainly not what you should be doing as a medical student. But I think the key point at that point is you've got an acutely unwell patient. You need help. Whether you think you can handle it or not yourself, you need at least some extra pairs of hands. So get some help, get some senior advice. All right, so let's say they don't have that. Then the next question you've got to ask yourself is this broad? Okay, because it's very easy to say, oh, they're going very quickly, and then not look at that QRS complex. If they've got a broad QRS complex, then I think really we'll be talking about ventricular tachycardia's next lecture, but in general, you need to be getting senior help and advice, okay? Because although it's possible that it's a type of AVRT or AVNRT, potentially with some bundle branch block, I think it's really silly to think of it like that. You need to be treating this like it's ventricular tachycardia if it's a broad complex tachyarrhythmia. So get some senior help. And when I say get senior help, if your med-reg or your senior, your SHO is not getting back to you quickly enough, it is very appropriate to put out a cardiac arrest call in this situation. All right, next question. Is it regular? Okay, so you now know you've got a patient who's relatively stable, they've got no adverse features, it's a narrow complex tachycardia. Is it regular? Okay, if it's regular, then we can go on to treat it like an SVT. If it's irregular, then we should treat it like atrial fibrillation, and we'll cover that in the next section. Okay, so you've decided this is an SVT, so you've got a narrow complex tachyarrhythmia in a relatively stable patient. So in terms of the principles, the key thing is you've got to block the AV node. I've said several times now that that's the central component of the AVRT, AVNRT pathway. Okay, and if you block the AV node, you can break that circuit in either of those arrhythmias, allowing the patient to revert to sinus rhythm. And so here you can see you've got AVNRT, you've got the signal conducted down that slow pathway, and then it's coming back up the fast pathway. If when it comes up that fast pathway, that slow pathway is still refractory, then the arrhythmia will terminate. Okay, so that's all you've got to do. You've just got to make it refractory long enough to stop that signal going back down the AV node. And with the AVRT, if you can block the AV node, then when that signal comes back up through the accessory pathway, it has nowhere else to go, and that circuit will stop. Okay, so how do you block the AV node? Well, one option is to use the vagus nerve. So as you may remember, the vagus nerve, cranial nerve 10, travels down through the rest of the body and supplies the parasympathetic nervous system, at least to the midgut, doesn't it? And so if you can trigger the vagus nerve, you can increase parasympathetic stimulation to the AV node, and that reduces the rate of conduction that the AV node is able to maintain. Okay, and so that's the first thing I would try. So you can undertake what are called vagal maneuvers, okay? And there are two key ones to know about. So the first is you get the patient to blow on a syringe, okay? Or get them to cough, but blowing on a syringe is particularly good. And what that does is increases intrathoracic pressure and therefore increases stimulation of the vagus nerve as it runs through the chest. Now, this essentially causes a Valsalva maneuver. Now, in particular, I would suggest that if you are going to do this, you try something called the modified Valsalva maneuver, which involves having the patient sitting back in bed. They blow on the syringe, and they only need to blow on it for a few seconds, and then you get them to lie back and you put their legs up in the air, and that is supposed to be more successful than just getting them to blow on a syringe. Okay, if you're interested in that technique, which I would suggest you should be, there's plenty of YouTube videos showing you how to do it. Now, the other option is to try and trigger the diving reflex, and you can do this by sticking somebody's head in cold water. And what this does is it triggers a reflex in all mammals, which is very strong in things like seals, and it aims to reduce your heart rate, and this is supposed to conserve your oxygen supply while you're underwater. Now, the diving reflex is much more profound in children and gets less and less intense as we get older. And so it tends to be used more effectively in a pediatric population. I'm mentioning it to you simply so that you know it exists. I would strongly recommend that you don't go around trying to find bowls of cold water and dunking relatively unwell patients' heads in them, because the patient won't thank you, neither will the ward or A&E sister for getting water all over the floor. So it's something to know about, but not necessarily something to do. So for vagal maneuvers, I'd really stick to getting to blow on a syringe. So you've tried stimulating the vagus nerve and that hasn't worked. The next thing to do is to move on to some drugs. And in particular, you're looking at ones that block or slow the AV node. There's lots of them, but the ones to have in your mind are adenosine, beta blockers, and calcium channel blockers. Now, you need to remember that calcium channel blockers come in different groups, and the group that you want for the AV node are non-dihydropyridine calcium channel blockers, for example, verapamil. But let's start with thinking about adenosine. Okay, so thinking about adenosine. Adenosine is a signaling molecule. There are adenosine receptors within the AV node. Okay, and stimulating these receptors reduces the function of the AV node. Adenosine has a really short half-life, and when I say really short, I mean less than 10 seconds, which means that you need to prepare yourself for giving this medication, and you need to give it in a particular way that ensures it reaches the heart as quickly as possible. So in terms of preparation, I'd lie the patient down, okay, and that's essentially because you're going to give them adenosine. What that's going to do is, hopefully, it's going to fully block the AV node, and it may do that for several seconds. And so essentially you're going to have a patient whose heart isn't beating for a few seconds. So they're not going to have a blood pressure, so I would lie them flat. Okay? Because you need to get this medication to the heart as quickly as possible, you need a large bore IV access. I would ideally get a green cannula, ideally in the antecubital fossa. You need to warn the patient that you're going to give them this medication. Okay? And that's because it makes them feel like they've got, quote, impending doom. Okay, it makes them feel like they're going to die. It's really horrible, and that's unsurprising because it's literally stopping their heart beating. Okay, so do let them know that they're going to feel pretty horrible. You need to have continuous ECG recording going. Okay, and ask one of the nurses to help you set up the ECG machine to do that. So instead of just rolling off a single 12-lead ECG like we normally look at in these lectures, it'll just run reams and reams of paper off over and over again while you're doing it. And that's important because it'll show you what's happening while the AV node is blocked. And I would aim to have a crash trolley available, okay, in case something goes wrong. Now, on top of this, I think it's important to know some contraindications to adenosine, and the big one is people who have severe asthma probably shouldn't have adenosine because it can cause bronchoconstriction. And I think if you're in that situation, if you haven't already, you should certainly be getting some help. Okay, so how do you give the adenosine? Well, think I would start with 6 milligrams. That's what the guidance says. Okay, and then if that doesn't work, you can try 12 milligrams after that. You need to give it quickly, and so I would give it through a 3-way tap, and you should have it the medication prepared in one syringe and a flush prepared in the other syringe on the other end of the 3-way tap, so that you can squeeze in the medication and then immediately afterwards squeeze in the flush, and that ensures that the medication, the adenosine liquid, travels to the heart quickly and reaches it as a tight bolus. Okay, so it can be really concentrated right at the AV node and block the AV node as easily as possible. Okay, once you've given it, you need to watch the ECG trace. Okay, you'll know if you've given enough because it should stop the heart beating. Essentially, you should get this flat line trace. Okay. It's really important that you remain calm at that point, okay? Because this trace can go completely flat for 10, 15 seconds. It will wear off, okay? Adenosine has this short half-life. The heartbeat will come back, but you need to remain calm, okay? Now, interestingly, because it's only blocking the AV node, you won't block any activity that's happening in the atria itself. So, for example, if you happen to have mistaken sinus tachycardia for an SVT of some kind, what you'll see is P waves going on. Okay, because you've blocked the AV node, but you haven't done anything to the sinoatrial node, so you'll see these P waves. And if you've mistaken atrial flutter, for example, then you'll see some flutter waves, that sawtooth wave patterns that we'll discuss in later slides. Okay. Now, if you don't block the AV node, if you still just see QRS complexes the whole time, then you probably need to give a higher dose. Okay. I think at the more junior stage, if you've given 6 milligrams and then you've given 12 milligrams and it hasn't worked, you should be getting some additional help at that point. Okay, because you can give higher doses, but it also may mean that you need to try something else. Okay, so these are a couple of pictures for you. So this is what I mean by like a 3-way tap. So you can see on this left-hand side, I appreciate that this is a mannequin that it's being given to. That's a plastic arm there, but you can see that the practitioner there is giving the medication with their right hand. So they're squeezing that in, and then that flush in their left hand is immediately ready to go straight after the medication has been given. And you can see on the right hand side that this is an ECG strip or ECG machine set up to read continuously. So instead of having those 12 leads in those 4 columns, you've got all the leads from top to bottom running along at the same time. Okay, so I know I've said this several times now, but the last point of your principles of SVT management is get help. And you can do this at any time that you are worried, but especially if the above hasn't worked. So if you've given the vagus nerve stimulation a try and you've given some adenosine, I think at that point you should at least be ringing for some additional advice, if not getting somebody else to see the patient. If only because 4 eyes are better than 2, and everybody can miss something in the middle of the night. Okay, so we've talked about SVTs. And by SVT, I mean I'm using that colloquially to mean AVRT and AVNRT. So let's talk about atrial fibrillation, which I think is something that comes up very regularly in medical school examinations, but it's also an incredibly common arrhythmia. It affects somewhere in the region of 15% of those over the age of 80. Okay, so it's the most common sustained arrhythmia worldwide. Has lots of risk factors for it. So as we get older, if you're male, you've got underlying coronary artery disease, hypertension, if you're overweight, or if you've got lung disease are the big ones to know about, okay? But there's lots of others. Okay, and it's a problem with uncoordinated depolarization of the atria. Okay, so unlike the circuits that we've been talking about at the first half of this lecture, where you've got still coordinated activity, it's just not what you would normally want, you've got completely uncoordinated depolarization of the atria. And atrial fibrillation is not benign. Okay, so it's increased risk of mortality, stroke, and heart failure in particular. Okay, so it has quite meaningful outcomes to patients. And patients can be quite symptomatic with it, particularly with palpitations or breathlessness. And I see a lot of those patients in clinic. So here's an ECG example for you. Have a few seconds, pause the lecture, go through it. Okay, so let's go through it together. So as usual, no details, but let's say this is an 80-year-old man who's come in feeling breathless. You can see from a technical point of view that it's calibrated normally based on the rectangles on that left-hand side. In terms of heart rate, well, let's have a quick look. We've got 21 complexes there, so it's going at about 126 beats a minute. Okay, so we've got a tachycardia. What about the rhythm? Okay, well, let's look at that R interval. Okay, if we map that to the next one, we can see that the next one is actually shorter. Okay, and if we map it to one further along here, you can see that one's actually much longer. And so if you look at it, it's actually quite irregular. Now, I know that some tutors dislike the phrase irregularly irregular, but I think you've seen in the heart block lecture that you can have some irregularity to the QRS complexes, but this is quite clearly irregularly irregular. There's no pattern to it at all. So the cardiac axis here appears to be normal. You've got upward going QRS complexes in leads 1 and 2 on that left hand side there. What about P waves? Okay, well, let's have a look at lead 2. As I've said multiple times, lead 2 is probably the best one to look at P waves in. And you can see several deflections on the baseline if you're being very judicious. So are those P waves? Well, I don't think so. There's no clear association with the QRS complex. And actually those deflections all look very different. So that one on the left I'm showing you looks to be upward going. The middle one appears to be downward going. Then you've got one that looks a bit upward going again. And they don't really look like P waves, do they? They don't look like a clear, distinct wave. Okay, so I think that's important, that if you've got an irregular rhythm, I think I'm not giving the game away in saying that this is most likely to be atrial fibrillation. And people can get themselves into a real fuss because they then start seeing things, these sort of deflections on the baseline, they start thinking of P waves, and then you start to get into real trouble because then you think it's not atrial fibrillation when it almost certainly is atrial fibrillation. So I think when you see these deflections in the baseline, you've got to really ask yourself, are these consistent shapes? Are they consistently associated with QRS complex? Because although the atrial depolarization is not coordinated in atrial fibrillation, it is still depolarizing in this uncoordinated way. So there will still be some deflection in the baseline caused by depolarization in the atria. They're called fibrillation waves. Okay, so having determined that there aren't any P waves, we can't really say anything about the PR interval. The QRS complex appear to be narrow. They don't appear to be too large. There's no signs of left ventricular hypertrophy here. You might say that there appears to be some small Q waves in lead 3, but I don't think that they're particularly pathological. The ST segments all appear to be isoelectric, and the T waves, they're potentially slightly flat in the lateral leads, but I don't think there's any signs of obvious ischemia here. So in summary, this is atrial fibrillation with a fast ventricular response. Okay. So principles of atrial fibrillation management. So I think the first thing to say is that the best thing to do is to try and get some rate control. Okay, we want that ventricular rate to be less than about 110 beats a minute. Okay, and there's a study here by Van Gelder et al. In 2010 where they looked at trying to whether it was beneficial to try and get the heart rate consistently under 90 beats a minute, or whether it was okay to just keep it at 110. And actually there was no real difference in outcome, and so this slightly more lenient rate control is probably absolutely fine. So aim for a heart rate of less than 110 beats a minute. Now another option is to say, well, instead of just slowing them down, why don't we try and get them back into sinus rhythm? Well, you can do that, and that can be beneficial for people who still have quite a lot of symptoms, even though their heart is going at a normal rate. But actually, in terms of actual outcomes, the AFFIRM trial in 2002 showed that rhythm control, so getting them back into sinus rhythm, is no better than rate control. And that's no better for stroke either. So that's something to bear in mind. Now, in terms of rate control, the drugs you can think about are beta blockers, so something like bisoprolol, calcium channel blockers like verapamil, or digoxin. And I would be cautious about starting people on digoxin because it's not a particularly effective drug, and it's probably overused. So it would be lower down that list. In terms of rhythm control, you have a few options. So one would be to give some medication like flecainide, which is a class 1C antiarrhythmic agent, or amiodarone. Problem with flecainide and amiodarone is that they can both cause quite dangerous arrhythmias, as well as getting you back from atrial fibrillation to sinus rhythm. And so flecainide particularly probably shouldn't be used in anybody with ischemic heart disease or structural heart disease. Amiodarone has other complications. For example, it can cause thyroid dysfunction, liver dysfunction, lung fibrosis, and so that should all be borne in mind. And it's not an effective long-term therapy because of those side effects in most people. You could try just cardioverting them, so giving them some electricity to get them back into normal rhythm, or they can undergo a procedure called an ablation, where the parts of the atria that are causing atrial fibrillation can be burnt away or electrically isolated from the rest of the atria. So apart from rate and rhythm control, so you've dealt with the arrhythmia in some way with those. So you've either slowed them down or you've got them back into sinus rhythm. You then need to think about anticoagulation, okay? And that's because atrial fibrillation has this increased stroke risk. And you should also think about risk factors for atrial fibrillation and whether there's any modifications there that can be made. In particular, there's evidence that if patients lose a good deal of weight, they can massively reduce the symptoms from atrial fibrillation and can actually reduce the chances of staying in atrial fibrillation longer term. And hypertension control is probably worth thinking about, although the evidence suggests that it doesn't necessarily impact ongoing atrial fibrillation. Okay, so let's briefly talk about atrial fibrillation stroke risk. So here's our left atrium. And importantly, we have a left atrial appendage, which sort of is the appendix of the left atrium. Okay, it comes off one of the surfaces here, and it's a little blind-ended tube. And being that shape, it ends up having relatively limited blood flow at its distal end. And that situation is made worse when you're in atrial fibrillation because the atria themselves aren't contracting effectively, which means that blood isn't being squeezed out of the atria effectively. So there's even more limited flow in that left atrial appendage. So you can get a blood clot forming there, and that's where blood clots tend to form. And these can fly out of the left atrial appendage and embolize to the brain in particular is where we're worried about for strokes, but they can also embolize elsewhere, causing other damage. So to stop that, you've got a couple of options. Option one is to make the blood thinner, which is to anticoagulate them. And generally this is pretty cheap, although the newer oral anticoagulants, the direct action forms like rivaroxaban, apixaban, dabigatran are all certainly more expensive than warfarin. They're still relatively cheap. They're also pretty effective, so they'll cut your stroke risk roughly in half. But because they make your blood thinner, they do come with a bleeding risk. And that's less of a problem for the newer oral anticoagulants than it was for warfarin, but there still is an increased risk of bleeding both into your brain as well as into your gut. And so that's something that we have to counsel patients about. So option two is to block the appendage. So you can get a device and you thread it up from the patient's groin normally into the heart, and then you position it over the mouth of the appendage and expand it there. And then it doesn't really matter if the blood behind it clots off, which it almost certainly will do, because it can't go anywhere. Now this is sort of relatively expensive, certainly up front. The procedural cost is quite high. It's supposed to be pretty effective, the evidence suggests it is. But there's an upfront risk as well, so you're having an invasive procedure. which comes with risks, but you don't have the same increased bleeding risk that you have when you take an anticoagulant. And so this is particularly useful for patients where they've previously had significant problems with bleeding, or you think they're very high risk of bleeding. So atrial fibrillation stroke risk management has been well defined by the European Society of Cardiology and laid out in a guideline, the reference for which is at the bottom right of your slide. But essentially it boils down to needing to undertake a risk assessment for your patient. Not all atrial fibrillation patients have the same risk of stroke, and they suggest using a CHA2DS2-VASc score to do this. This is the CHA2DS2-VASc score, and you'll see that you get points for a number of comorbidities, as well as age and female sex. And the guidelines suggest that if you have a score of 2 or greater and you're a man, then you should definitely be offered anticoagulation. And if your score is 1 or more as a man, then it should be considered. And if you're a woman, they say if the score is 3 or more, then you should have anticoagulation strongly suggested. And if it's 2 or more, then it should certainly be considered. Now, the points are 1 higher if you're a woman, because one of the risk factor points on the CHA2DS2-VASc score is female sex. So a man and a woman who have everything else the same, a woman will have a 1 point higher score. But the female sex in and of itself, if you have no other risk factors, doesn't increase your risk of stroke. It just modifies and worsens the other risks on this score. And that's why there's a difference in the points you need as a man or a woman to be considered for anticoagulation. So 2 or above in a man definitely should be strongly considered to have anticoagulation, and 3 or above in a woman strongly considered. Whereas 1 in a man and 2 in a woman, then it should certainly be thought about and discussed with the patient. Now, your options to reduce your stroke risk are either anticoagulation, and that can be done with a direct oral anticoagulant like apixaban, or a vitamin K antagonist like warfarin, or as we discussed, there are some other options, particularly left atrial appendage occlusion devices, which are primarily considered in people who can't tolerate anticoagulation for whatever reason, or have previously had problems with it due to bleeding. And so it's really a second line intervention there. So moving on to talk about atrial flutter now. It's important to know that it's a cousin of atrial fibrillation, or at least it can be thought of that way. A lot of patients who have one either have or go on to develop the other arrhythmia. The risk factors are similar as those for atrial fibrillation, as I've outlined on a previous slide. But unlike atrial fibrillation, which is this truly disorganized atrial activity, atrial flutter is actually a reentrant circuit within the right atrium. And I'll show you a bit more about that on another slide. And unlike AV-NRT or AV-RT, the AV node is not a central component of the circuit, but it is important for rate control. Okay, so atrial flutter, what we can think about is if let's take the atria, let's cut them across like this and have a look down. Okay, and this is our right atria here. And so we've got the front and the back of it. You can see that we're looking down, and you can see the tricuspid valve leading into the right ventricle, and you can see the inferior vena cava there. Our left atrium is off towards our left. And what happens is a little circuit can form that goes around the inferior vena cava. And it importantly has to go through this area here, the cavo-tricuspid isthmus, which essentially is a very fancy way of saying the bit of tissue that separates the tricuspid valve from the inferior vena cava. And this is a narrow bit of tissue, and so the conduction is quite slow through it. And because it's slow enough, it allows time for the rest of the atria to repolarize. And so it allows this circuit to develop around the right atria. So we've got this circuit, and because of the cavo-tricuspid isthmus, the circuit takes about 200 milliseconds to complete. And because it takes 200 milliseconds, that means there's about 300 circuits a minute. And each time the circuit goes round, it depolarizes the atria. Okay? And signals reach the AV node, And the ventricular rate depends on how many signals, what proportion of the signals the AV node receives, that it actually transmits down to the ventricles. So there's a degree of AV node block that occurs. And this is an important function of the AV node, so this is not the same as heart block. It's a mechanism by which the AV node stops 300 beats reaching the ventricles a minute. So because it's a degree of AV nodal block, it's receiving 300 signals a minute. And so the heart rate will be a factor of 300. So if it's letting through every other signal, then the heart rate will be 150. If it's letting through 1 in 3, then the heart rate will be 100. Letting through 1 in 4, 75, and so on. So that's useful to remember, that if it looks like it's a factor of 300, you may well be seeing atrial flutter. So here's a nice ECG example. Again, have a couple of seconds to go through it. Okay, so hopefully you've had a chance to pause the slide and go through it. Let's start from the top. So no particular details here. From a technical point of view, I'll tell you that again, this is one of the ECGs that I got from a slightly dodgy ECG machine where the technical calibration strip on that left side is incorrect. This is actually calibrated normally. The heart rate appears to be going at about 75 beats a minute. So there appears to be roughly 4 squares between each R wave. It's a little bit variable, but it's pretty much on there. You can see that here. Take that apart, you can see that there's 4 large squares there. So 75 beats a minute. And I've highlighted what I think might be going on here by saying that 75 is, of course, 300 divided by 4. So what about the rhythm? Well, I think the rhythm is pretty regular. There is a little bit of variation there. I can see some R waves that are about 4.5 squares apart, but it's certainly not the profoundly irregular rhythm that we saw on the previous ECG. What about the axis? Well, that appears to be pretty normal. P waves, well, okay, let's have a look at those in a bit more detail. So there are certainly some regular deflections from the baseline, and you can see those in lead 2 as well, and they're upward going in lead 2, so you might say, well, are those P waves? Well, they're each 1 large square apart, okay? Which means, given that we know that the ECG machine takes 300 squares across a minute, if it's 1 square apart, then there are 300 of them occurring each minute, okay? So that might give you a clue as to what might be going on. And I think certainly when you're looking in V1, you can see a sawtooth-like pattern. I've pulled an image of a saw off of the internet here, and you can see that it does look pretty sawtooth-like. Okay, PR interval, well, you can see here that it's about 180 milliseconds from the deflections that you're seeing just before the QRS complex, so that's pretty normal, and that suggests that those deflections there probably are triggering the QRS complex there. The QRS complexes are narrow, and then there's no features to suggest left ventricular hypertrophy, so you've got a narrow complex rhythm here. ST segments don't look particularly deviated. I think it can be hard to tell, for example with V1, where clearly you're getting this sawtooth motion through what would be the ST segment, so that can be difficult. And the T waves, I don't think there's any significant deflection, but again, I appreciate that it can be difficult to tell because of this sawtooth wave. So in summary, this is a patient with atrial flutter, and you can tell that because they've got this sawtooth wave that is, they're each about 1 large square apart, so you've got these sawtooth waves occurring 300 times a minute, and you've got a heart rate that's a divisor or factor of 300. And so this all fits together to say that you've got atrial flutter with 4:1 AV block. So I'm just going to finish off here with a little bit more terminology. I've picked out things that I hear being used incorrectly quite frequently. So one is pre-excitation. So this is evidence of an accessory pathway on a resting ECG. So that's that shortened PR interval with the delta wave. And so that, if you see that, that's pre-excitation. I hear the phrase Wolff-Parkinson-White being used a lot. Wolff-Parkinson-White is a syndrome, which means it's a collection of signs and symptoms. And in particular, it's evidence of pre-excitation on an ECG with either palpitations or evidence of having a supraventricular tachycardia, a narrow complex tachycardia. Whereas I hear a lot of people using the phrase Wolff-Parkinson-White to simply mean that they've got pre-excitation on their ECG, and that's incorrect. And finally is the phrase fast AF. Now, this is not one that particularly bothers me, but I know it bothers some people. And that's because the atria are always fibrillating quickly in atrial fibrillation. So fast AF is a bit of a misnomer because all AF is fast. And what people say you should be using is the phrase atrial fibrillation or AF with a fast ventricular response. Because what you mean when you say fast AF is that the heart rate, the ventricular rate is fast. Like I said, it doesn't bother me, but it does bother some people. And this second way of saying it is probably technically more correct. So it's perhaps something that we should all start doing. Okay, so we've reached the end of the lecture now, so let's just go through the learning objectives to make sure we've covered everything. I appreciate it's been a particularly long lecture, this one, but hopefully you feel we've got some good content under our belts. So we've described the criteria for a narrow complex tachycardia. So broadly and simply, it's a heart rate greater than 100 beats a minute with a QRS complex less than 120 milliseconds. We've gone through the ECG patterns for different forms of narrow complex tachycardia, particularly AV-NRT, AV-RT, atrial fibrillation, and atrial flutter. We've definitely gone through the physiology behind the common narrow complex tachycardias. And we've described basic management for a patient with a narrow complex tachycardia. And I can't emphasize enough that if you're worried, if you're in doubt, you should certainly get help. And then we've talked about the more general management considerations for a patient with atrial fibrillation, particularly thinking about stroke risk. So as usual, if you've got any questions, please touch base with me either by email or on Twitter. I'm very happy to answer any questions I can or point you towards resources where you can find the answer out for yourself. But I very much hope to see you in the next lecture. Thanks.